Hi, I'm Tony Stile. I'd like to think I was asked to give this talk because I really like to work with this group, this population of patients. I fear that it's because I'm just old. And, I started as a psychiatrist in addiction treatment in 1972. Some of you were not born then. And thanks to Mikey Flaherty, I actually started in narcotic addiction treatment programs in 1980, right? 79 or 80. Yeah. The funny story about that, Mike, and IRETA, Scott Johnson was the director, and they hired me, and I came in, and for about 6 months I worked in the narcotic addiction treatment program in Pittsburgh, and then they said, IRETA said to Mike, you think it's time to tell him? And I said, tell me what, Mike said, yeah, I think he's been here long enough, I think he's going to stay, I think we can tell him. And what they were going to tell me was my predecessor, Bill Moody, who was a psychiatrist working in that program prior to when I did, one morning was walking into the methadone program and got kidnapped. He was walking in with his, walked in with a little briefcase, and apparently people were watching him, thought he had methadone in the briefcase, and threw him back in his car, kidnapped him, drove him to some part of Pittsburgh, searched him through the. So they didn't tell me that until 6 months after I took the job, and I was already sort of hooked in dealing with this population. So, I'm going to start actually with the last slide. I don't know why I would do that, but I am going to start with the last slide because we're going to talk about patient respect and advocacy, and I wanted to start off with the macro system and then work down to the micro system. So in the macro system, we all know that there's a great deal of pushback when we try to open up a methadone maintenance or narcotic addiction treatment program using methadone. Actually, Act 10 was a very good example of that kind of pushback, which my understanding is that Act 10 has been declared unconstitutional, right? So it no longer applies. However, there are local ordinances, local zoning, there's community groups, there's all kinds of pushback when programs are attempted to be open. And actually, there's a bill in front of the House that I think I'm correct, where the bill basically says that people who are on methadone, on methadone, have to have a designated driver to drive them to and from the program. And I think it's open-ended. I don't think it's just in the first couple of weeks of being on methadone, which is actually, by the way, a very tricky part of the induction process. Maybe somebody should drive people to the narcotic addiction treatment program when they're being induced. But once they're induced, there's more than enough evidence. I came up with many Department of Transportation studies that showed very clearly that, once you're on methadone and stably on methadone, that the psychomotor effects of methadone are quite minimal. And this is in both paper and pencil tests and computer-generated tests. So, a lot of this stuff, a lot of this pushback doesn't meet the proof of studies. But our role in terms of advocacy really has to start at the macro system. We are, and again, I assume I'm preaching to the choir because you're here, so I'm assuming you already respect and are advocates of this population to start off with. So most of what I'm going to say, I really feel very comfortable in saying because all of you believe it 100%, correct? Right? Good, okay. So the community is very important. Going out into the community, and for physicians, the medical community and how we access and interact with the medical community is very important. I was an oddity in 1972 as a psychiatrist in chemical dependency treatment. People looked at me funny. They looked at me even funnier when I started on narcotic addiction treatment in 1980. That was like a psychiatrist and doing methadone maintenance. Are you crazy? So, but maybe I am, but in any case, going out into the community and actually, giving many talks in the medical community and then the lay community has been part of my role. The other thing is, Arvita mentioned that she tries not to tell her neighbors what she does. And which is kind of interesting. I'm sure they all know what you do, but Work for health, okay. But once you start working in this field, you are identified as working in this field. And so it's very important that you're a model. When you do and say stupid things, a lot of times it comes back on the field. It's not just you. If you're a private practitioner in your own office and you say or do a stupid thing, it reflects back on you personally. If you're in a narcotic addiction treatment program and identified as one of those people that does that, and you say and do something stupid, then it reflects back on the field. So, not only do you have to go out and be positive, you also have to be a good model. Okay? So the community is very important. Now, going back in terms of some advocacy programs, and this is in your handout, National Alliance of Methadone Advocates, the International Center for Advanced Addiction Treatment, Advocates for Recovery Through Medicine. These are all nice websites that you can go to. Maybe even get involved in advocacy at a national level or at a local level. The other one that we'll talk about in a little bit is the ATOD, the American Association of the Treatment of Opiate Dependencies, which has a meeting every 18 months. I don't know, how many of you have been to ATOD meetings? Oh, goodly amount, okay. I think the next one, Laura, is what, April or May in New York? April 2009 in New York. It's an every 18-month program, internationally attended, on basically treatment of opiate dependencies. Very, very excellent program to go to, so I would recommend it. Where am I going here? Okay, elements of advocacy. Improving the quality and accessibility, James talked about this, of pharmacological treatments for opiate, specifically opiate replacement therapy, buprenorphine and methadone. Excuse me. Eliminating discrimination against patients in these treatments. This new House bill is really a discrimination against patients on methadone maintenance. Creating more harmonious relationships between patients and treatment providers in the community. I think you were talking about this, Dr. Taylor. As well as empowering methadone patients. I'm trying to remember. Pro-A, any of you are familiar with Pro-A? Advocacy program for basically alcoholism and other addictions. But there are very few public advocacy programs and very few programs where patients have empowerment. So it's important to help empower the methadone population and the buprenorphine population, okay? And educating patients, medical personnel, policymakers. I had a very interesting case when I was at Allegheny General running the substance abuse consult team after Dr. Fuller did. We're in the trauma center, and you'll love this. A patient comes in, was drinking and driving, had an accident, broke their femur, they're in the trauma center. They're giving him morphine, right? The morphine isn't working. They give him more morphine. The morphine isn't working. So what do they say? Drug addict. Drug seeking. What's wrong with this person, right? Well, if you had read the little card that was in their wallet and you knew what Revia was, which they were on for their alcoholism, okay, you would have known that giving them as much morphine as you want isn't going to work because they're on 50 milligrams of Revia every day and it's an opiate blocker. But it was like dumb look when I said to them, well, this patient's on Revia, so why are you giving him morphine in the first place? So, but medical personnel, they don't understand it. They don't understand methadone. They don't understand buprenorphine, and they ask the dumbest questions. So educating them is very important. Now, backing up. And again, all of you know this. This is a reminder. I mean, you all know this. Beneficence. Do good. Right? Autonomy. Enforce the autonomy of the person, the recovery model. Non-malfeasance. Don't do harm. For those of you that sort of remember, was it Hippocrates? Yeah. I get confused with Hippocrates. Hippocrates said, don't do harm. Do no harm. First of all, do no harm. Non-malfeasance. And justice. People have to be treated in a fair and just manner. So this is the elements of the ethical program. Now, the ATOD Canon of Ethics, and again, it's the American Association of the Treatment of Opiate Dependence. This is what they recommend. Canon of Ethics. This is treating patients with respect and advocacy. Number one, ensure patients are treated with compassion, respect, and dignity. Retain competent and responsible personnel. That's what you were talking about, Mike, right? In terms of, not just assigning somebody to be the methadone medical director, but actually having them know something. There's an old story about, if you're going to teach a dog a trick, you should be smarter than the dog. Right? It's a truism. Right? Subscribe to the treatment principles in the back of the room, tip 43. How many of you have noticed that the tips are getting bigger? Man, I can remember when you had those little bitty things, you know, like 30 pages, and 15 pages were references. Now, how many of you have actually, well, how many of you have picked up the co-occurring disorders tip? Just picked it up. All right, so you got some exercise. How many of you actually read the thing? All the way through? God bless you. No, I read pieces of it, you know. But the whole way through, that would be like a 3-year course. I'd get an MBA if I read through that whole thing. So, but the treatment principles in tip 43, very important. Medication-assisted treatment for opiate addiction and opiate treatment programs. Okay? Provide patients with accurate and complete information regarding treatment, available nature. One of the things that I think we have to get back to the basics of is that a narcotic addiction treatment program is treating people with addictive disorders. And so it's not enough to give them methadone, 2.5 hours of treatment a month, not check permit them to take benzos, not check for marijuana because what would you do about it anyway? I mean, these are the kind of things that I think give our field a bad name, okay? And definitely give patients bad treatment as far as I'm concerned. You know, at St. Francis, we were a zero-tolerance benzodiazepine program for 12, 13 years. Our new program now, SPHS Behavioral Health in Blairsville, Pennsylvania, zero tolerance for benzos. Who's somebody from New York? New York, okay. At the last ATOD meeting, they were talking about Nassau and Suffolk County programs going totally non-benzo by rule.
I don't know.
Okay. That was the lady at this, because we had a huge forum. It was about the size of half of this room. And it was on benzodiazepine use in patients, on narcotics, on agonists. And of course we were not for it, and there were a lot of people that weren't for it, and a lot of people weren't really sure. But the folks from Long Island said that as of, I think, January 1st, by law, by regulation, the methadone programs in Nassau County and Suffolk County, which are two of the larger counties on Long Island, were going, you know, no benzos. If you're on methadone, you couldn't be on a benzodiazepine. Ensure that the discharge from treatment is conducted in accordance with sound principles, not financial principles, not can't pay, gotta go. Okay. Although, you know, patients have to also take responsibility in the recovery model for paying for their own treatment. So, and provide a safe and clean environment where patients and staff can do therapy. Remain in compliance with all the laws, take the necessary measures to maintain patient records in a confidential fashion, strive to maintain good relations with the community. That's very important. How many, I guess you have to have a community board, right? Is that a requirement for the community board? It's not?
It depends how the organization is structured.
Oh, okay.
If it's a nonprofit, then it would have a board of directors, which is usually made up of community. If it's a for-profit, it could be the shareholders.
Oh, okay. All right.
So it all depends on the legal entity.
Okay. Well, the community advisory function, I think, is very important. Getting people involved that are in the area is very important. And maintaining good relations with the community. Of course, that was very difficult when they're Act 10. Okay, so let's go to the beginning again. This is a worldwide complex public health problem. And society gets stuck with it. This is the actual first slide, by the way. And of course, the health profession has to handle this. So, as such, we as physicians, and I don't know how many physicians are in the room. I don't know how many physicians are here. Well, a good number of physicians, okay. And then there's folks that also tell the physicians what to do, right? How many of you are there to tell the physicians? You tell the physicians, okay. Yeah. Essentially, use the greatest restraint, observing the strictest possible generally accepted medical indications, carefully monitored, and fully informing patients of therapeutic and non-therapeutic effects. You know, I'm an addiction psychiatrist. I'm certified as an addiction psychiatrist. So when people tell me, well, some of these patients have to have fill in the blank. You know, I'm an addiction psychiatrist, and one of my specialties is psychopharmacology, and I do a lot of clinical work with patients with addictive disorders. So I know what I'm talking about when it comes to fill in the blank and co-occurring disorders, and benzodiazepines in particular. So gotta be careful there. Physicians should be aware of non-medical factors. They should learn to recognize drug seekers, addicted patients, and this is within our programs too. The drug-seeking behavior within our programs, okay? Judicious use, for instance, of, and I think, Laura, you're going to talk about this, the how many nanograms per ml should your therapeutic level be, okay? Are you going to talk about that?
We'll mention it.
Okay. How many days can go by before you cannot give anybody their full dose, that sort of thing? I'm being told to move ahead. Okay. Let us, end here. Physicians have an important role to play in the treatment of drug addiction. We all know that, okay? Both as clinicians and as advocates of treatment rights and dignity of individuals addicted to the harmful substances. So I would encourage you to advocate, they say about what, a husband's, best thing a husband can do for his kids is love the mother, right? Well, the best thing doctors can do for opiate-addicted individuals is treat them with respect and dignity, enjoy working with them, and treat them only in the best possible evidence-based manner.
Hey everyone, my name is Ed Salsitz. I'm from New York City. I work at Beth Israel Medical Center. And I'd like to thank both Drs. Taylor and Drs. Flaherty for having me here. I've worked with them on a number of different projects and always enjoy working with them. And I also, over the years, have developed other colleagues in Pennsylvania who have become good friends and colleagues, Laura McNicholas, Adam Gordon, and others. One of the things I would mention is I am an internist pulmonologist, and then I segued into addiction medicine about 20 years ago, is I've noticed that the folks in addiction medicine in general, and particularly those that work in opiate agonist therapy, are some of the friendliest, most collegial people, and even some of the government folks like Nick Ruda and Bob Lubrand fall into that category. So it's a nice group of people, and it's always nice to work with them. Tony, one thing I have to say about your talk is that I'm wondering if you actually are a dog owner, because there is no owner that can be smarter than his or her dog. That is an impossibility that the dog takes care of within about 2 or 3 weeks of living with you. And everyone who owns a dog knows that's true. All right, so I've got too many slides as usual, but since I'm preaching to the choir, I think I won't have to spend much time on each of them, and I want to get through. Right, okay, thank you, Adam. So I'm going to talk about some things related to my own experiences with methadone, which come out of working in an office-based research sort of program for the last 23 years. And I would say that in a counterintuitive sense, even though I've never worked specifically in a methadone clinic, I've gained a lot of knowledge about what happens in methadone clinics across the country, because people have applied to my program from all over the place. And they've told me things very honestly about what's happening in their programs, and I'm going to share some of that material with you. These are my financial disclosures these days. Now, one of the things about opiate agonist therapy that I came to understand to be true is that it's a relatively complicated topic. And one of the pitfalls I think most people make is to think, oh, this is a simple thing, heroin addiction, you're on methadone, man, there's not much to talk about. I think Adam would agree that on internal medicine rounds, not much is ever talked about in a methadone patient. Nobody brings in a paper. Why is one person on 100? Why is one person on 40? What the hell is this all about to begin with? And it's just sort of left there. So, and one of the peculiarities about addiction medicine is that in that first circle, addiction, what is addiction anyway? How do you define it? And this is one of the things that's different in addiction medicine than, let's say, diabetes, is all of us who are good doctors probably have a different paradigm of what addiction is, why people become opiate addicted, how you see this disease and why it's happening. A lot today is going to be on the medical part about methadone. I looked through the slides that are coming up, and there's an intensive presentation today about many of the issues related to methadone as a medication. Regulatory issues have been talked about a little bit, but methadone is unique in the number of regulatory constraints that surround the drug. No other drug in America has this type of regulatory environment. I'm going to talk about stigma. Politics means that any politician can win points by saying, hey, you know what we're going to do? We're going to close down all the methadone clinics in Pennsylvania. That's a political winner. For a while for Giuliani, it worked in New York, and then it backfired. And I want to talk about destitution. Let's go back to sort of the beginning of methadone treatment. Here's a picture of Dr. Dole, Dr. Neiswander. These were the people who really got methadone started in the early 60s at Rockefeller University. Dr. Dole was an internist interested in metabolic problems. Dr. Neiswander was a psychiatrist, and she worked in these narcotic farms. Laura McNicholas and I were in Lexington, Kentucky last weekend, where one of the narcotic farms, the Lexington narcotic farm, was located. But she found that they kept relapsing and relapsing no matter what she did psychiatrically with these patients. She had a particular fondness for jazz musicians. And Dr. Dole became intrigued with her work. He said something simple. He said the reason that they're relapsing is their brains lack something that the heroin is providing, and that's why they keep going back to it. This was 10 years before the endogenous opioid endorphin system was fully recognized, and people understood that there were these natural opioids that all our brains are making. And that's why Dr. Dole is considered to be someone who was, I'll use the word genius. And then, of course, Mary Jean Creek joined this team shortly after it started. And those of you that know Mary Jean Creek know there's hardly any more impressive scientist in the world, probably, with the caveat that after about 15 minutes of her talks, very, very few people, Laura's probably an exception, can understand what she's actually talking about. But you believe it's really real. You can take it on faith. And this trio published a number of papers. Now, this is 40 years ago. A medical treatment for heroin addiction. Sounds simple today, but 40 years ago, that was a revolutionary thought. Or go to the last paper, heroin addiction, a metabolic disease. Not a character problem, not a criminal justice problem, not a morality problem, but an actual medical disease that could be understood and could be treated with an effective medication. Now, it's always important, these kinds of talks, to say that all treatments work for some people, but no one treatment works for all people. So me and no one else says that the only treatment for opiate addiction is opiate agonist therapy. It happens to be, from an evidence-based point of view, the most effective treatment over a 40-year period of time. But other treatments work well. Abstinence-based treatments work. Naltrexone works for some people. So that's the caveat, even though I certainly am an opiate agonist therapy advocate and do believe it's the most effective treatment. And this medication psychosocial battle that still goes on. So here's the paradigm of I medicate first, ask questions later. So here there's no psychosocial. And the other one is, sorry, no water, we're just a support group. And it turns out that for most people, the combination of pharmacotherapy and some psychosocial treatment works best, whether it's alcoholism now, or opiates, or most problems, most behavioral problems. So just because I want to have a little science in my talk, like some of the other speakers, there was a study done in 1999, and they looked at people who were on methadone for a short time. I think a short time was about 6 months. They had long-term methadone patients in the middle bars over here, and they were on methadone for about a year and a half, and then they had control people in the white panels. And they looked at metabolites in the brain, something called phosphocreatine, and then phosphomonoester, phosphodiester. And you can see that as patients stayed on methadone, they more closely resemble the controls than the people who were on a shorter period of time. At the time this was published, Dr. Leshner, who was the head of NIDA, said this was the most important paper ever published on methadone maintenance, because it's showing that the methadone is actually working in the brain, normalizing and stabilizing important brain functions. Phosphocreatine is supposed to be a factor for brain bioenergetic status, and the monodiesters are reflections of brain cell membrane integrity. And one of the mistakes that people make is just giving the people these opiates, and what are they doing? Well, they're doing something in the brain, and Dr. Dole always said the point of this was to normalize and stabilize the brain so that the person could then do effective and good rehabilitation work. And he felt the other way around, there was too much craving to do good work because the brain was craving opiates. And In the study, the conclusions they come to, looking at the last sentence, the nearly normal metabolite profile in the long-term methadone subjects suggests that prolonged methadone may be associated with improved neurochemistry. And of course, the only way anybody can get better from any addiction problem is to change their brain, since addiction is a chronic brain disease. And you've got to normalize and stabilize it either with medication, psychotherapy, other psychosocial maneuvers. But the brain must change if things are going to get better. And then there was an NIH consensus panel in 1997 that showed that methadone was a very effective medication, and they recommended increasing the access and cutting down the barriers to access. And usually when you have an NIH consensus statement, it becomes kind of something that people respect and look to. But in the case of methadone, it was just another well-done document that people didn't pay much attention to. Now, so we have this great drug. It really works. It does good things for the neurochemistry of the brain. What is this big problem with methadone 40 years later? So here's a nice shot of our main Beth Israel building on First Avenue. I must admit that it generally doesn't look like this at night, but this is a good shot. And we're a tertiary kind of hospital, medium-sized for New York City. And this is our main intake methadone program, which is on 2nd Avenue and 25th Street. For those of you that know methadone, beige bricks, iron gates. It doesn't say Beth Israel. It certainly doesn't say methadone on it. And there are all these community oppositions all the time. New York Hospital is always in the top 10 hospitals in the country whenever they're listed. Right along the East River, it's a beautiful place, Cornell, New York Hospital. Here was their methadone clinic on the corner of 1st Avenue, 71st Street, beige brick building, iron gates. I think the original architect for methadone programs is Frank Lloyd Methadone. Because all of them are the same. This clinic happens to have been closed now, and they moved it to a side street in a similar kind of building that doesn't look like the rest of the hospital. Mount Sinai Hospital, that's Central Park in the background there, one of the premier institutions in the world, New York City. They have a building by IMP with this atrium. Really, it's incredible when you walk in. It's like walking into a museum. It's such a pretty building. Their methadone clinic is located a couple of blocks away in a parking garage. And so, there's a theme, there's a message here about this life-saving drug that was developed at Rockefeller University, which is really the big time, in terms of biomedical research. And that clinic was closed. The hospital decided they couldn't have that clinic anymore. They were going to tear down that building and build condos. And they just said 400 patients were closing the clinic. It was a big battle. I don't know if you folks were involved in the battle, Bob and Nick, to try to move it to a different place on the campus. They closed it down. The people had to be scattered to other clinics, which can make a big difference in a person's life if you're going, 3 blocks to the clinic, and now they have to take a bus or a train to go to the Bronx. So that's another thing that happens. Clinics can close that way. And Albert Einstein, which is where we have our academic affiliations at Beth Israel, is a pretty good medical school and university hospital in the Bronx. And some of their clinics are still in these trailers in these parking lots. It was supposed to be out of there a long time ago. But, you tell a patient this is a life-saving medication, well-researched, a lot of evidence, but you have to go to this kind of peculiar place, and you have to go 6 days a week for at least 3 months. Gee, that's unusual, right? So a number of years ago, Dr. Dole had taken out this IND so his wife, Dr. Neiswander, could give people a month's worth of methadone in an office-based setting. And in 1985, he transferred that to a group of us at Beth Israel. And this eventually became something very interesting and important to me. Before I took these new patients who were stabilized and in remission, the only methadone patients I'd ever seen were in the hospital using other drugs, not acting particularly well. And I had no idea what methadone was about. Nobody seemed to read about it or care about it or bring in a paper. It just was they were on methadone. They were generally destitute patients, and that's how it was. First patient I get in this new program, Office Space, was a hospital employee. I'd known him. He was a good friend of mine. I never knew he was on methadone, a guy named Jerry Pendergast. And it opened up a new world to me of methadone patients who look and talk like all of you and who take their methadone like I take my Lipitor. Most people don't know these people exist because they remain hidden. And we've been doing this for a number of years now, for 23 years. Our program is closed down to new admissions for bureaucratic reasons. which is always the case with methadone. There's bureaucratic issues that come up that don't make clinical sense, but they happen. But we enrolled a total of 347 people. I only want to show you 2 or 3 things on the slide. We had 55 people who died, and these are all deaths unrelated to methadone or drugs. These are all rehabilitated people. To get into our program, they had to have 4 or 5 years in a methadone clinic. Last 3 years, urines were negative, working, using their time productively. So yeah, we took the best patients out of the clinic because they didn't need the services there any longer. Come in once a month, get a bottle of methadone in diskette form, and they come in every 4 weeks and they get primary care if they would like it. But the number 1 cause of death is tobacco-related disease, which is a hot topic in addiction medicine now, when to approach that, what to do about it. And then the second highest cause of death was hepatitis C. Of note is that we don't have a lot of HIV/AIDS in this group, and the reason is most of these people got on methadone before 1980. And they literally know that methadone saved their lives because they would have kept injecting, would have gotten HIV. And those of you that are old enough to remember 1980 know that when you got HIV in 80, 2 years later you were dead. We've only had about 12% of people have to go back to the methadone clinic, either for other drug use or selling their methadone, doing something wrong. But 12% over this period of time seems like pretty good results. Some people now are being transferred to buprenorphine. This number is up to about 26 now. And other things have happened to the patients, but it's been a very successful program. What we really need is office-based methadone alongside buprenorphine with proper training of physicians and proper safeguards. Medical maintenance, that's what we call what we do, happens in the Beth Israel Ambulatory Care Center. Huge, beautiful new place. And patients love coming in with all kinds of other people, not only methadone patients where you can be identified. They're coming in with OB, orthopedics, pediatrics, and they're in just a regular place sitting in regular waiting rooms. Nobody can identify what they're doing. Now, these are long-term methadone patients. The y-axis here is the number of years on the number of patients, and this is the number of years. So you see the majority of patients have been on methadone for 20-plus years. I've still got some of the original Dole-Niswander patients. A lot of people are surprised that people are on methadone for 40 years or 30 years. But the truth is that every study you look at show that these are the people who have been the most successful in their lives. And that makes sense. I mean, if I need to be on insulin and I stay on it, I'm going to be more successful than if I go off of it or my blood pressure medication. But people have not really come to accept this paradigm that in some people, not all, indefinite methadone is the way to go. Just like everyone thinks that indefinite Lipitor is the way to go. We don't argue about that. Now, what am I doing here? I'm from New York City. Well, I've got my colleagues from Pennsylvania, but I also have patients. I have 3 patients who come in from Philadelphia every month because they found coming in to see me and getting that 1 month supply of Diskette was better than what was happening in Philadelphia. I did have a patient from Allentown. She switched into a pain paradigm due to some back issues. There was a Lancaster program that did a month's supply. I don't know if that's still in existence, but my patient transferred into it. And I just saw this patient the other day. She was doing a PhD in Pittsburgh, and she was flying in every month into LaGuardia, taxi cab to the office and back. And let me tell you, she was nothing but grateful to have the ability to do that because the Pittsburgh programs at that time could not provide her with what she needed. She was also very worried about her anonymity in the PhD program. It's sort of peculiar that 40 years later, dosage is still an issue, and people are being held on probably inadequate doses. Now you can see there's been a lot of improvement. This is that Dunno article, and if you look at 1988, only 6% of people in methadone programs, they canvassed all of them across the country, only 6% were getting doses above 80 milligrams. So that has improved, but still, patients receiving less than 80 is 2/3, so only 1/3 are receiving over 80. So there's still this issue of sort of dose limitations, thinking about a dose that you can't go above, not based on any, not only not based on science, but going counter to all the science. When people come into medical maintenance, their doses usually go up because they haven't been able to do it in the clinic. And these days, this is how we get the methadone at Beth Israel Medical Center. We have it delivered by truck. So stigma. Stigma is a big deal. A mark of disgrace or reproach, a mark indicating that something is not considered normal or standard. When we sort of took an informal look at the patients in medical maintenance, we found that they held the methadone to be much more stigmatizing than being HIV positive, being gay, having used heroin, having used alcohol, having been in prison. Nothing was being held more secret than I'm on the methadone program. Some people don't tell their spouses. Nurses will say, I hear how the nurses talk about methadone patients in the hospital. I will never ever disclose to anybody that I'm on methadone. And of course, when they're in medical maintenance, they have their own methadone that they can take surreptitiously when they're in the hospital without anyone knowing that they're taking it, because they're not in a program where the program has to be called. And the bottom bullet, physicians, most physicians don't really know about this, don't understand it, and once you say to the physician, I'm on methadone, first question you usually get asked is, when are you getting off of it, or you can't get any pain medication. Same thing with dentists. So a lot of education to be done among physicians. As opposed to other stigma, when your socioeconomic status goes up, from what I've seen, the stigma goes up. In other words, the people who are at the lower socioeconomic level are out there saying they're on methadone, they'll go on TV, they'll be in newspapers, but it's the ones who do better and better in life who keep it more and more secret. And that's unusual. Usually in other parts of our life, when socioeconomic status goes up, people feel better about themselves rather than hiding things more. So Nassau County, Tony, you mentioned Nassau County before. Somebody gets locked up in there, he's on methadone, he's in for a driving violation there, 90-day sentence. He's on methadone, he keeps asking his guards, am I going to get the methadone, I'm going to get the methadone, when am I going to get the methadone? They really become annoyed by this asking. 3 guards go into the cell, they beat him up. 3 days later, he's dead in his cell of a lacerated spleen. This was a big deal. The jail guards got 11 years in prison for killing the guy, manslaughter, killing him in his jail cell because he was asking for the methadone. And of course, Nassau County, almost $8 million, and it's a county that can't afford that. So where would this happen with any other medicine, right? It couldn't, but it would happen with methadone. And then the New York Times, a number of years ago, had this photojournalism shoot about Mariella, and it says she's on methadone and she uses cocaine and got a syringe in her mouth, a pose picture. And that, for many people, is the methadone patient, the stereotype of the methadone patient. Here was one of my patients, Jimmy Maxwell. He looks like he ought to be on Mount Rushmore. He has this patrician look. He was a jazz trumpet player. He played with Benny Goodman. He played with Arturo Toscanini. And for me, most importantly, he was in a Tonight Show band with Johnny Carson. And we would come in, we would talk about Johnny Carson and Ed McMahon. It was a lot of fun. He died at the age of 78 or 80. Had a wife and 2 kids. Lovely guy. And so he's the methadone patient to me. This is what I think of when I think of a methadone patient. Pearl Parker died of emphysema. She has her methadone in this little bag of hers in here. She was in a different hospital, not my own. Nobody knew she was on methadone. Even at 77, she was ashamed to tell people, and she kept it a secret and just took her methadone when no one was in the room. People are amazed that there are methadone patients who drive buses, like this patient drives the Avis bus at the airport. Again, Laura and I were in Lexington doing a Butte course last week, and there was one physician there, seemed like a nice guy. He was adamant that it's impossible that a methadone or buprenorphine patient could have cognitive abilities and do this kind of work, that it would be an impossibility for this to happen. And we went over it and over it. I just sent him a bunch of articles, and I'm sure he's not going to think that it's true. Tom Pay, who many of you know, had a patient in Texas transferred to me, and what she does is teach people how to ride horses and jump and all of that. When would you think you'd see a methadone patient who, a picture like this, jumping horses? Now, I am thinking of putting the horse on methadone. Giving it consideration. Why is methadone so demonized and stigmatized? It's a great medication. Why? Well, it's got a terrible molecular structure. And this is the L-form of the mu agonist isomer. And then it has the other isomer, the D-isomer, which may be an NMDA antagonist. And this is how people think about methadone. They said to Dr. Doe, you're going to make zombies out of these people, Vincent. They're not going to be able to function. And, of course, he proved them all wrong. Now, buprenorphine right now is not demonized, and we have a job not to let it be demonized. It has a very nice molecular structure right now. But we have to make sure it doesn't turn to this, which it could if the right circumstances occur. The New England Journal of Medicine, you got to think of the top part of the slide as the cover. Review articles, that was the cover. Drug therapy for breastfeeding women. That's something I definitely want to know about. Open up the inside. drugs of abuse, cocaine, marijuana, okay, methadone, listed under drugs of abuse. Right away, you see, you ruin any argument, the whole discussion's over. Methadone is generally not, unfortunately, lately it's creeping up a little bit, but certainly when this was published in 2000, methadone was not really a drug of abuse, and in fact, it's okay for methadone-maintained patients or HIV-negative women to breastfeed their babies. Here's a lovely guy. His baby's about 6 or 7 now. He's with me in the medical maintenance program, and his wife doesn't know he's on methadone. He's afraid to tell her, afraid what the repercussions might be. How about these addiction treatment centers? I don't want to mention any names because I got into trouble doing that one time. But do they really give people a fair presentation on opioid agonist therapy? Do they go through all the options of the treatment availability for opioid addiction, that there is methadone, that there is buprenorphine, here's the data on it, there's naltrexone. I do that with my patients, I'm sure the other doctors here do that as well, but they don't. And I mean, I've heard many patients say, the counselor told me that methadone is worse than poison, certainly worse than heroin. And you'll come in for your 5th detox, and no one will say, opioid agonist therapy. They'll say another drug-free, abstinence-based spiritual recovery. And again, all treatments work for some people, but usually in medicine, when what you're doing fails, you switch to something else. Addiction medicine is a little bit different. It seems that lots of times just you're doing the same thing over and over again. Unfortunately now on these pre-employment drug screens, they're throwing in a 10-drug panel that has methadone in it. It didn't used to, but that works out through the MRO process as long as it's prescribed. And what we say is that buprenorphine is really not being checked for, so that's a little advantage for buprenorphine. This is not about Dick Cheney and his shooting there. This is about the big snowfall that happened in New York. Your clinic appointment is Monday. On Friday night, you start hearing about the big nor'easter. There's a big nor'easter that's going to dump 48 inches of snow on New York City, and you're thinking, how am I going to get to the clinic? I got to drive there. What's going to happen? What if I don't get there? Anxiety. Just what you want in a person who's in remission from addiction, right? Stress and anxiety. These are things that cause relapse. So here are the bottles that are typically dispensed in methadone clinics, all these bottles with the liquid. Here's what we dispense, diskettes and tablets of methadone, a nice bottle. But just think of this. Think that you get a 2-week take-home, the clinic is okay, they give you that, you're going on a trip. How do you go through security now with this? You can't fit 13 of these bottles in the plastic bag. And so where do you put them? Do you check them? Do you wonder if they get there on time? What do you do if you don't have the methadone? You're going through with your 16-year-old kids, somebody reaches in there and says, what are all these crazy bottles here with this red liquid? Do they leak? Don't they leak? All of this torment, all of this torture, for what purpose? There's no purpose. The regulations say you can dispense oral methadone, which means you can do diskettes. So many clinics now say, well, we just haven't been able to do it, we don't do it. We don't do it. It's murder to make somebody go through the airport security with these bottles when they can have this, and it's legal by federal regulations to dispense the tablet formulation. When they come back, how do you know if they're still clean? This must be a Tide detergent ad. No, it's an ad for urine testing. My friends, this is a clean urine, and this is a dirty urine. In no other field of medicine, when we talk about urines as being clean and dirty, urologist, as Peter Lundstone, no, he doesn't say that to a patient when a patient comes to see him with a kidney stone. I look at your urine, boy, it is dirty. He doesn't say that to people. He says it's got red